Next, talk about inter and supranuclear problems. So here's really what we're going to try to cover. Internuclear ophthalmoplegia, one of the more common eye movement dysfunction patterns you're going to see. Skew deviation with a vertical misalignment of the eyes. Vergence problems, divergence or convergence, paresis or insufficiencies. And phorias. This is a common diagnosis we'll see in the clinic, decompensated phorias. And most of us are not perfectly ortho. Most of us have a little X or a little E. And yet you confuse that and not have diplopia because your fusional mechanisms allow you to get your images straight on the fovea. This brings us back to our pre-test. And just to show you again the problem.
Sure, okay.
Now, what's going on here? Does Mike Myers have a 6 nerve palsy? Who thinks he's got a 6? One person in the back, that's about it. Anybody else have thoughts on this? We'll come back to him. So you've seen our tour. We're now into the internuclear and supranuclear issues. And let's begin with another case. What's going on with this patient? She comes in with episodic diplopia. She's an engineer, so it's binocular horizontal. You can just shout out a diagnosis. We've got to get you warmed up for tomorrow. The tables and chairs are bolted down starting tomorrow. Anybody have a diagnosis here? Any brave soul want to volunteer something? Who thinks this is a bilateral INO? Who's deep in REM sleep and not even here? Yeah, that's right. This is a bilateral INO. And that's really the point I want to make here. So if you look in the textbooks, you will see this pattern for an internuclear ophthalmoplegia. You know the 6th nerve lives down in the pons. The 3rd is miles and miles up in the attic, in the midbrain, and if that all works, then the eye actually goes in. If it doesn't work, then what you're going to see is this kind of pattern where neither eye can AD duct to midline. This is a bilateral INO. This is what we would call an orthopedic INO, because even an orthopod would recognize this. And most of your INOs are not orthopedic INOs. This is the exact same lesion. AB ducting nystagmus to help you. AB ducting nystagmus here. The clue is to look at the bridge of the nose and have them saccade right and left. As you watch the bridge of the nose and have her saccade, you will not miss that AD ducting slowing.